Hi, everyone. My name is Matt Riedel. I'm one of the orthopedic trauma surgeons at Yale New Haven Hospital. And tonight I have the honor of having a discussion with Dr. John Anderson. He's a professor of orthopedic surgery at Michigan State University. He's the co-director of the Foot and Ankle Fellowship out there at Grand Rapids Orthopedics. And he wrote a really great article on lisfranc injuries. It's titled Open Reduction Internal Fixation versus Primary Arthrodesis for Lisfranc Injuries. It's a prospective randomized study. So welcome, Dr. Anderson, to our discussion tonight. And thank you again for taking the time to join us and for doing this study.
Thanks for having me.
Great. Our first question is, why did you decide to do this research? What brought you to have this clinical question, and what made you want to do it?
We, in our foot and ankle practice, do a lot of midfoot fusions, for all kinds of reasons, but we see a lot of degenerative problems with midfoot arthritis and flat feet, and we do a lot of TMT fusion procedures for hallux valgus and deformity correction. So it made sense to us that these joints, we knew they did well when they were fused, and it made sense to us that traumatic disruption of these joints really weren't all that different from a functional standpoint than traumatic disruptions of cervical facet joints. Trying to preserve motion in these joints just didn't make sense to us. And the big question was whether we can reliably get a fusion in the traumatic population, or does the non-union rate go down when there's soft tissue disruption associated with trauma? So we thought our study would be a great way to answer that question, because we were big fans of midfoot fusion procedures from the get-go. And we were pleasantly surprised that our non-union rate did not go down.
No, I saw the one non-union in all patients that were in the fusion group. That's really a fantastic rate. One question I had for you, I noticed that you guys fixed, when you had the fixed group, you fixed with screws and you didn't plate. Is that kind of the standard way that you guys fix them, is with intra-articular screws, or have you guys switched to plating options?
Back then, it was we just weren't doing a lot of plate fixation in that area. Nowadays, I think if we have a hard time getting lag screw fixation, we would certainly use plates, and I use plates much more frequently now. Particularly if open reduction internal fixation is entertained, there may be situations where you don't want to do a fusion, and spanning plates are much more protective for the joint than screw fixation.
And that's the reason I ask, is I know, often you take the implants out, but just in terms of post-traumatic arthritis, and putting an intra-articular screw through the joint may lead to some of that post-traumatic arthritis. Maybe using spanning plates would help prevent some of that necessity.
Yeah, I think that's a good point. And then, the nice thing about this paper is our results, functional results, were pretty similar. The biggest difference in our paper was the reoperation rate was lower with a primary fusion. But I think there is still a role for open reduction internal fixation, and for some people, it's just more in their skill set. They would much rather do a ORIF than a fusion. And I think this paper shows that they're both still viable options.
Sure, and I think you're right. I don't know that it would change the hardware removal rate to use plates and screws. In fact, I think it would be just as high. Most people would probably want those out, or the plates may break, etc., in the ORIF group. But yeah, that was just one question that I had, was much of that happening back when the study came out, or was it mostly intra-articular screw fixation?
Yeah, our protocol was at least 2 lag screws across each joint. Mm-hmm. So this study was completed in the early 2000s. So that was kind of our standard at that time. The nice thing was they were all treated by fellowship trained either foot and ankle or trauma surgeons, and we all had very similar protocols for surgical reduction and type of fixation and postoperative management. So there really wasn't a big variable in terms of which surgeon was treating that patient.
Right. And I know that you were saying you guys were doing a fair amount of midfoot fusion back at that time. Did this study push you more one way or another in terms of how you're treating them currently?
We've been primary fusers since probably 2000. So I was a fuser even before this study came out because of my experience doing midfoot fusions for all sorts of other things. Our trauma guys were doing open reduction internal fixation, and we enrolled them with the expectation that we would probably swing them in how they manage things. And in reality, I think we still have some trauma guys that prefer not to do fusions for these injuries. But I was a fuser before this study came out, and this just reinforced my belief that this was a good operation.
Great. And did you find that, I'm sorry, did you find that you did sway some of your trauma colleagues more into the fusion group?
Yeah, in our community, it's predominantly primary fusion now.
Another question that I have kind of following up with that, I know that you got 53-month follow-up. You were able to call most of the patients. Do you have any longer term follow-up, especially on the ORIF group of how they did maybe 10 years out, 15 years out?
I think that's a great question. We're actually looking into that, but we don't have that data yet.
It's hard to find patients that far along.
Yeah, particularly trauma patients. Yeah, they tend to disappear. But I can say that having been in this community for 25 plus years, I don't see a lot of ORIF patients coming back needing fusions. And I don't see a lot of fusion patients coming back getting revised. So these patients are, for the most part, doing quite well. And I'd be very interested to see if there's a higher revision rate going forward. My suspicion is that the fusions, once they're healed, they do really well over the long term. Whether they have adjacent joint arthritis or the ORIF patients come back with fusions and how they're doing from a functional outcome standpoint, we just don't know.
Yeah, I think that's always been the big worry, is adjacent joint breakdown and disease in the fusion group. But you think you're not seeing much of that with your patients that you have out there?
No, and even in our fusion population for degenerative conditions, we are not seeing a lot of adjacent joint arthritis. We tend to do a lot of gastroc releases, and I tend to do a lot of gastroc releases even in my lisfranc population. When they're tight and there's an Calcaneus contracture and I'm treating a lisfranc with a primary fusion, I tend to do a gastroc, and I think that really unloads the adjacent joints. So that may be why we're seeing small numbers of adjacent joint arthritis coming back long term.
I think that's a great point. That's something that I've also started incorporating in both my fix and fuse lisfranc or Calcaneus or anything really midfoot or hindfoot, and that comes from one of my partners who's been a big proponent of that. And I agree, I've seen a big change in my patient outcomes, even in my short career thus far.
Yeah. Yeah, and I think that's something that I would encourage everybody to take a look at that's treating these injuries. in the reconstructive population, the Calcaneus contracture is everywhere. Yeah, so we're doing a lot of Calcaneus correction for people with metatarsalgia, people with flat feet, people with midfoot arthritis. And you see this in the traumatic population as well, not just in midfoot fractures, but in ankle fractures and polytrauma. So it's certainly something to look for.
And I think another great point from the paper, you were fusing 1 and 2. How often were you fusing 3? I know 4 and 5 you obviously wouldn't fuse. There's so much motion through the lateral midfoot. But was 3 oftentimes included, or was that kind of a surgeon's discretion?
Yeah, our protocol was we would get intraoperative stress films on everybody. And if 3 opened up, they were included in the fusion. If the injury stopped, if it was a subtle lisfranc and it stopped at the second TMT or the lisfranc interval, then we would do it all through a single dorsal incision and stop at either first TMT or first and second, or transverse fixation from the first to the second.
Mhm.
So our lisfranc screw in our study might have been a true oblique lisfranc screw, or more commonly it'd be transverse screws from the first metatarsal into the second metatarsal, or first cuneiform into the second cuneiform. But we would take it all the way across if the third TMT joint opened up on stress films. And 4 and 5 we pinned, so that those joints we considered mobile joints that were essential, and they were not included in the arthrodesis population.
Right. And when were the pins removed from 4 and 5?
Pins removed from 4 and 5 at 2 months.
2 months. Because I believe all the deep hardware would come out at 4 months on average. I believe it was in the study, right?
That's right. That's right. And I think a lot of people now that are doing ORIFs and putting hardware in may even consider leaving the hardware in and not routinely taking it out, which probably would have equalized our results had that been an option.
Which would functionally be an arthrodesis if you think about it, with the joint spanned by the implant.
Right. We call them closet fusers. Yeah.
Nice. Anything that you think you'd want to add to any of the answers or discussions, or any thoughts you have?
Yeah, I think one parting comment I would have is in this paper, the one consistency we had was everybody had fixation that progressed from medial to lateral.
Mm-hmm.
I think I still see a lot of people that are treated where their medial fixation is a single screw across the lisfranc interval from the medial cuneiform to the second metatarsal. All of ours had fixation across the first TMT joint. And I would just emphasize that if you do stress fill, do an abduction stress, in order to get a lisfranc ligament injury, there has to be a medial TMT injury or a medial NC injury that allows the first ray to push the second ray over. So transverse fixation may miss that injury. Most of the lisfranc injuries in this study, and pretty much all the ones that I've seen, when we open them up, the medial first TMT capsule is torn. Mm-hmm. So I see a lot of injuries that are treated surgically where there's no fixation across that joint. And I think the emphasis would be just to make sure you look for that. So
absolutely. No, that's a great point. Very well taken. And thank you for making a point of addressing that, because I think it's something that, like you said, is not maybe taught often enough or not recognized often enough, and can really lead to ongoing instability after the fixation. We really thank you for your time. This has been really fantastic, and thank you for doing this study. It leads to a lot of insight.